Lisa Hill, 64 years old, is walking down the sidewalk in Willows, California. The afternoon sun beats down on the quiet main street, brick storefronts, empty parking spaces, a faded American flag hanging motionless in the heat. She's clutching her chest, her face turning purple, gasping for air. 2 blocks. That's how far she had to walk to the emergency room at Glenn Medical Center. If Glenn Medical hadn't been there, I would have died, she told me later. The hospital 2 blocks from her home closed 6 weeks ago. Lisa Hill is not alone. Right now, across 43 states, 55.94 million Americans are losing access to emergency medical care, not because of a pandemic, not because of a natural disaster, because of a policy decision made in Washington on July 4th, 2025. This is happening right now. I need you to do something for me. Pull up a map of your county right now. Find the nearest hospital to your home. Now calculate the drive time in minutes. Now consider this. What happens if that hospital closes next month and the nearest emergency room is now 32 miles away? For 376,000 Americans in affected regions, that calculation just became a death sentence. I'm Helen Morland. This is the Morland Report. The mainstream media is calling this market consolidation and strategic healthcare realignment. I call it what it is, the systematic abandonment of rural America. I spent 15 years inside hospital administration and healthcare policy. I sat in the boardrooms where these decisions were made, and I left because I couldn't stay silent anymore. Let me show you what's really happening. To understand this crisis, you need to understand one number. 56%, that's the percentage of their net income that independent rural hospitals are projected to lose in 2026 alone, just to cover the cuts to Medicaid reimbursements, Medicare sequestration penalties, and site-neutral payment reductions. What they got? Nothing. On July 4th, 2025, Congress passed the One Big Beautiful Bill Act, H.R. 1, slashing $900 billion from federal Medicaid spending over 10 years. No rural exemptions, no transition period, nothing. For urban hospital systems with diversified revenue, this is survivable. For rural hospitals operating on 2% margins, this is an execution order. Here's what they're not telling you. I obtained internal financial projections from the American Hospital Association dated June 2025. According to their analysis, 734 rural hospitals, 1/3 of all rural hospitals in America, are now at immediate risk of closure, not financially stressed, at risk of closure. They are losing money on every Medicare and Medicaid patient they treat. The One Big Beautiful Bill Act didn't create this crisis, it accelerated it. Let me break down how the system is supposed to work. Rural hospitals receive reimbursements from Medicare and Medicaid based on the cost of care they provide. Each year, these rates are supposed to adjust for inflation and rising labor costs. When costs go up, payments go up. That's the deal. Except in 2026, Medicare payments were cut by 2% through sequestration, and Medicaid payments were slashed through work requirements, eligibility redeterminations, and federal matching rate reductions. They cited fiscal responsibility and program integrity. Internal memos from CMS, documents I've reviewed, show projections that H.R. 1 would save approximately $900 billion over 10 years. What those memos don't calculate is the cost of what happens when 376,000 Americans lose access to emergency care. And this is where it gets really disturbing. Let me tell you about Glenn Medical Center, Willows, California, Glenn County, population 6,200. Nearest alternative hospital, 32 miles away in Chico. Glenn Medical had been operating since 1966. 3 generations of families were born there. The ICU where farmers came after tractor accidents. The ER where ranch hands got stitched up on Saturday nights. Last December, they announced financial insolvency. By February 2025, they closed their doors permanently. I spoke with Lisa Hill, 64, a Willows resident who depended on that hospital for decades. I was walking down the street when I couldn't breathe, Lisa said. My face was turning purple. I was about to collapse right there on the sidewalk. I only had to walk 2 blocks to the emergency room. 2 blocks. They got me oxygen, stabilized me, saved my life. If I'd had to drive 32 miles to Chico, I wouldn't have made it. I would have died in my car or on that sidewalk. Lisa paused. That hospital saved my life, she told me, and now it's gone. This woman was lucky. She got sick before the closure, but I spoke to another resident, a woman who asked not to be named, who said this after the closure. I should have told them that without this hospital, I probably would have died. She meant it literally. She had a medical emergency 3 weeks after Glenn Medical closed. The 32-mile drive to Chico, the waiting, the fear. She survived. Barely. This is not an isolated incident. This is a pattern. Since 2023, 18 rural hospitals have closed or converted to models that no longer provide inpatient care across the United States. But here's the acceleration you need to understand. 44 additional hospitals converted to rural emergency hospital status in the last 14 months alone, losing their ability to admit patients overnight. The American Hospital Association released data last December showing that 152 rural hospitals have closed or discontinued inpatient services since 2010. Let me show you the numbers state by state. Texas has lost 26 hospitals since 2010, more than any other state. 47 more are currently at risk. Tennessee has lost 16. Kansas, 6 closures, but 46 hospitals currently at immediate risk. 87% of Kansas rural hospitals are operating in the red. Mississippi, 28 hospitals at risk of closure. Alabama, Lawrence Medical Center closed in 2025. Thomasville Regional closed in 2024. These aren't random distributions. They cluster in 3 specific patterns. Non-Medicaid expansion states, 69% of closures from 2014-2024. Counties with populations under 10,000, communities more than 30 miles from an urban center. And here's the key to everything. Rural hospitals serve patient populations where 50-60% are on Medicare or Medicaid. When you cut those reimbursement rates by 56% of net income, these hospitals have no way to make up the difference. An urban hospital system can shift costs to privately insured patients or cut less profitable service lines. A rural hospital serving a county of 6,000 people with 60% on Medicaid, there is no cost shifting. There are no other revenue streams. When HR 1 hit, they don't have a cushion. They have a cliff. Now watch what happens when a rural hospital closes. It's not just the emergency room, it's the entire healthcare ecosystem. The specialists leave because they can no longer admit patients for overnight observation or surgery. The visiting oncologists, the cardiologists, the OBGYNs who drove in twice a week, they stop coming because there's no facility to practice in. The dialysis centers close because they can't survive without the hospital's infrastructure and referral network. The ambulance services get overwhelmed with 32-mile transfers to the nearest hospital, so response times double, then triple. A study from the University of North Carolina tracked mortality rates for time-sensitive conditions in communities after rural hospital closures. What they found should terrify every American. Inpatient mortality for heart attacks and strokes increased by 8.7% in the years following closure, not among the elderly, across all age groups. For time-sensitive conditions, heart attacks, strokes, traumatic injuries, every additional 10 minutes of travel time increases mortality risk exponentially. These are not statistics. These are your neighbors, your parents, your children. Let me tell you about Jellicoe Medical Center, Campbell County, Tennessee, population 40,000. Jellicoe Medical closed in 2021. Sounds like old news, right? Ancient history in the healthcare crisis timeline. Here's what that means in practice. Tanya Brock, a healthcare quality manager and Jellicoe resident, watched it happen. Under the old model, a pregnant woman in labor would drive 10 minutes to Jellicoe Medical. Under the new model, she drives 30 minutes to the nearest hospital with a labor and delivery unit if she's lucky and there's no traffic. The hospital employed 300 people. When it closed, those jobs vanished overnight. We lost our healthcare lifeline, Tanya told me. Local businesses started failing. People moved away. The entire community started to hollow out. And they said, the market will correct itself. Alternative providers will step in. No alternative providers stepped in. The closest emergency room is now 30 minutes away for a heart attack, for a stroke, for a child choking. That's the difference between life and death. This is not a funding problem. This is a policy choice. The administration's response has been what I can only describe as willful blindness. In June 2025, the Secretary of Health and Human Services testified before Congress that HR 1 included targeted investments in rural healthcare infrastructure. He pointed to $400 million in rural emergency hospital conversion grants, $400 million for a crisis affecting 55.94 million people. That's $7.15 per person. Meanwhile, internal documents from CMS show they're projecting accelerated facility conversions and strategic consolidation through 2034. That's bureaucratic language for more closures. They know, they're planning for it, and they're not telling you. Now, I need you to understand how this cascades. When a rural hospital closes, the domino effect is devastating. First domino, emergency response times. Kaiser Family Foundation data shows that average travel times to the nearest hospital in affected rural areas have risen from 12 minutes to 32 minutes. For cardiac arrest, for stroke, for severe trauma, survival rates drop 10% for every 10 minutes without intervention. Second domino, workforce exodus, rural America was already facing a physician shortage. The American Hospital Association estimates a deficit of 124,000 physicians in rural areas. Hospital closures accelerate the exodus. Why would a young doctor or nurse move to a county without a hospital? Where would they work? Where would they send their own family in an emergency? Third domino, economic collapse. Rural hospitals are often the largest employer in their county. When they close, the job losses ripple through the entire community. Property values drop, tax revenues fall, schools lose funding. Fourth domino, population collapse, families leave, young people don't come back, the community hollows out. This isn't theoretical. This is already happening in Lawrence County, Alabama, Glenn County, California, Campbell County, Tennessee. And here's what happens if this continues for another year. The Charty Center for Rural Health projects 300 additional immediate closures by late 2026. The American Hospital Association estimates 734 rural hospitals will enter critical financial distress by 2027. According to their models, 1 in 3 rural Americans will live more than 30 miles from an emergency room. Have you noticed how quiet the administration has been about this? Have you wondered why there are no emergency task forces, no presidential press conferences, no intervention? Because they're hoping you won't notice until it's too late. What happens when your elderly parent has a stroke and the nearest hospital is 45 minutes away? What happens when your child stops breathing and you're 32 miles from an emergency room? What happens when you are the one having a heart attack in a county with no hospital? This is not speculation. This is the trajectory we are on. Here's what you must do. First, map your emergency care access right now. Not just the nearest hospital, but also urgent care centers, trauma centers, stroke centers. Have addresses ready. Know which facilities can handle which emergencies. Know the drive times at 2 a.m. with no traffic. Second, have the conversation with your family now. Discuss contingency plans if someone has a medical emergency. Consider personal medical alert systems for elderly family members. Know their medications, their conditions, their doctors. Third, document everything. If you experience delayed care, if you have to travel excessive distances for emergency treatment, if you lose access to a hospital, record it, report it to your state health department, file complaints with CMS. The only way this changes is if the evidence becomes undeniable. Fourth, if you're outside rural areas, don't think you're safe. Urban emergency rooms are already feeling the overflow from rural closures. When 734 hospitals collapse, the pressure transfers to you. Your wait times will double. Your ER will be overwhelmed. I need to hear from you. Comment below right now with your county and state. Tell me, how far do you live from the nearest hospital? Has your local rural hospital closed or reduced services in the last 2 years? Have you or someone you know been affected by delayed emergency care? Subscribe right now. Share this video with everyone in your community who needs to hear it, because the people making these decisions in Washington are counting on your silence. History is being written right now, and we are documenting it in real time. I'm Helen Morland, and this is the Morland Report.